Good afternoon and welcome to the 2020 VHHA Lunch and Learn webinar series. This webinar series will focus on quality, patient safety, and high reliability in healthcare facilities around Virginia. My name is Krista Burnett and I'm the Director of Patient Safety and Quality in the VHHA Center for Healthcare Excellence. I'm your moderator for today's presentation. Before we get started, there are a few housekeeping items I need to share with you. This webinar is being recorded and all participants are muted. Questions and comments can be entered at any time. They will be addressed at the end of the presentation. We have a short feedback survey that will launch at the completion of the webinar. The slides for today's presentation are available in the handout section of the control panel, and this series is just a one-time registration, so everyone today is signed up for all subsequent events. So I'll take a minute now to introduce our two presenters. They're from Sentara Careplex Hospital, and we have Tracey Odachowski, and she has been with Sentara Healthcare since 2007 as a critical care staff development educator for 3 years, a clinical nurse manager for 9.5 years, and most recently, the interim director of patient care services for inpatient nursing since May of 2020. Her bedside experience includes med-surg telemetry floor and cardiothoracic surgical ICUs. A native of Eastern Shore of Maryland, she earned her Bachelor's of Arts in Biology from the College of Notre Dame of Maryland in 1998, Bachelor's of Science in Nursing from the Johns Hopkins University in 1999, and Master's of Science in Nursing and Health System Management from Vanderbilt University in 2010. Additionally, she holds certifications as a Certified Critical Care Registered Nurse and as a Nurse Executive Board Certified. Krista Byalik has been an infection preventionist with Sentara Healthcare since 2016. She started her career in healthcare in 2004 as a volunteer EMT with the Blacksburg Volunteer Rescue Squad. She first joined Sentara Healthcare in 2008 as an ED tech at the Port Warwick Emergency Department. In 2011, she left Sentara and spent several years working in quality assurance in the blood plasma industry before rejoining Sentara, where she discovered her passion for infection prevention and patient safety. She earned a Bachelor of Science degree in Biology from Virginia Tech in 2004. And additionally, she maintains the Certified Healthcare Operations Professional certification from DNV GL Healthcare USA. Her role as an infection preventionist allows her to draw upon her vast array of professional experience, from her work in research and development to patient care and safety to quality assurance. She's a native of West Virginia, but has been a resident of Hampton Roads for over 30 years. She enjoys spending her free time with her husband and her twin boys. Welcome to Krista and Tracey, and the floor is now yours.
Thank you so much, Christy. In case you need to spell out our very odd names, they're now on the board for you. If you can go ahead to the next slide. The one thing I want everyone to kind of get used to is we do like to do things through laughter and humor, so we'll try to inject a little bit of that into this. So hopefully it'll help make it a little bit lighthearted. But this is really where we were at the beginning of this. So we know that it could be prevented, and so our challenge was to try to figure out how. So next slide. By the way, this is Tracey speaking right now. So the background, CAUTIs are a tough one to kind of put in a particular place. The CAUTI cost ranges are kind of all over the board when you look in the research. What we were able to find is they range somewhere in between $4,600 and $29,000. It just depends on what's going on with the patient. But that's kind of a good estimate from all the different places that have estimated out there. But the biggest thing about a CAUTI is by far it decreases patient safety. It increases your length of stay, your cost of follow-up care, your susceptibility to C. diff, sepsis. I think the one thing that we said when we started all of this is, you know, nurses have joked about Foleys over the years. It's rare to hear a nurse say, oh, I'd love to have a CVL, but how many of us have said over time, I'm going on a long road trip, I'd love to just put a Foley in. And so the seriousness of Foleys and what actually can occur with them just didn't seem to be as front of mind as it did with other devices. And so that was a struggle to try to change our minds about those and get it in there. Next slide. So, which is exactly why we did this. So please, God, help me convince the doctor to keep the bladder catheter until I'm done with my shift, said every nurse ever. And I will admit, when I was a bedside nurse, I probably did the same thing. You almost felt good that they had a Foley because that made something a little bit easier. But it's not about making things easier, it's about making our patients safe. Next slide. So a little background of us. We are at Sentara Careplex Hospital. It's a 224-bed hospital in Hampton, Virginia, which is in the Hampton Roads area. We struggled quite a bit. So in 2016, we had 8 CAUTIs total with an infection rate of 1.48, and it got even worse in 2017. We had 9 CAUTIs in 9 months. So in that September of 2017, we said we really need to change things. How are we going to turn this around? And that is where this project was born. Next slide. So what we're going to do for you today is talk about reducing CAUTIs by creating a structured Foley Huddle, establishing a comprehensive daily review of any inpatient Foleys and ensuring the optimal care while trying to decrease on any unnecessary Foleys, and then identify and mitigate the risk factors to prevent CAUTIs. Next slide.
So this is Krista. We implemented a real-time daily huddle, and I know Tracey talked about what our numbers looked like in 2017 with 9 CAUTIs in 9 months. And this project was really born because I went to her office and I said, my boss is scarier than yours. She expects results, and I'm not leaving until we do something. And what we determined in that conversation is that we had one person in the house who was reviewing Foleys when she was able to, which wasn't every day. That person was Tracey, and that we needed to design a process, a huddle that would allow anybody to review the Foleys, know what they were looking for, know what questions to ask, and then know how to make sure the follow-up happens. We identified the required participants as our nursing leadership team, the unit charge nurses, infection prevention and control, and the hospitalist nurse. Next slide, please. So what did we review? Whenever we started this process, we reviewed the Foley necessity. Did we have an order for that Foley? Was that order appropriate? Was the order current? Because we do have 2 types of Foleys here, a temporary order that is good for 48 hours and a long-term order that does not require review and renewal every 48 hours. We reviewed the documentation to make sure the Foley was being cared for properly, that the patient was being cared for. We determined if a urinalysis and or culture were there results, did it look like the patient might need to have a UA done, things of that nature. We talked about challenging situations that may impact care and maintenance. And I'm going to give an example here. We at one point in time actually had a patient in the house with 2 Foleys. And so everybody who was at Huddle that day, I remember making the joke, well, unless the patient has 2 Foleys, we don't need 2 Foley orders. And the manager looked at me and said, Krista, she has 2 Foleys. And this was the type of challenging situation that our huddle allowed us to speak to and figure out what do we need to do in this case. And then we also evaluated the patients for the presence of diarrhea with the Foley catheter and whether or not they were a candidate for a fecal incontinence device to help keep the patient and that Foley clean. Next slide. So with IT's help, we were able to build a report in Epic. It's one of our workbench reports, and it identifies the information we obscured was the patient information, but it determines when the Foley was inserted, what time it was inserted, what is the Foley order, what are they charting, does the charted indication match the ordered indication, and that's where you see the checkbox, the green check, or the red exclamation mark. When was the last urine culture sent? Are they performing the care? What was the last stool that was documented for the patient? And then in the very far right-hand side of your screen, it told us if they had an FMS or not to help manage their diarrhea. So at a quick glance, you could tell a lot of information about that patient and their Foley without having to open each chart individually. Next slide. We also created this Huddle Process Job Aid so that The Foley review was not based on who was present to review the Foley, and anybody could step in, lead the huddle, and they knew what questions they needed to ask and how to proceed. When you look at this, we started looking at when was the necessity last addressed? Why has the Foley been in for so long? We ask this question a lot for our acute urinary retention Foleys, especially around Foley day 4, day 5. We really start going, what is the plan? Why is this still in for acute retention? Have we done void trials? And then we ask, are there any challenges to maintenance? We also looked at, was a UA sent, and should we look at sending one if it was a POA Foley?
The next slide, present on admission, sorry.
Here's the rest of that document. We did have to split it up over 2. So then we broke the document down, especially in the beginning, based on each type of Foley order. So we looked at our AUR Foleys. You know, has it been 48 hours? Does it still meet criteria, or can we remove it? If it was a long-term Foley order, you know, does the patient have a history of CUR? You know, is it documented in their chart? And can we manage this any other way? Does the patient perform straight casts while they're not in the hospital? Things of that nature. We looked at our critically ill Foleys to make sure they were in ICU. In our house, ICU is the only place where a critically ill Foley will go. So whenever we see a critically ill order on another unit, we challenge that to see if the patient needs to move or if the order needs changed. If they're not in ICU, is this Foley in for accurate daily measurement? Or is the staff completing the required hourly documentation? So the Foley's ordered and it says you need to document the output every hour. Are we doing that? Is the Foley still indicated, or has the critically ill criteria changed? Has the patient improved? We looked at our terminal comfort care orders to make sure that the patient's code status was in fact terminal comfort care, because we learned the hard way. We had several CAUTIs in 2016, 2017 that surrounded complicated end-of-life situations where we were in a boat where the patient was almost comfort care but not quite, so we were caring for them as if they were comfort care, and then the family or somebody would say, no, we want to be full code. So we really looked at those terminal comfort cares to make sure the order matched the code status. We looked at accurate daily measurement to make sure they were documenting the I's and O's, and then we evaluated other ways that we could perform the accurate daily measurement that didn't involve a Foley catheter. We looked at our Foleys for any other indication, prolonged immobilization, assisted healing, bladder irrigation, to make sure it was still indicated, and that the order was appropriate. Next slide. Challenges to making this process happen. I don't even know where to start. We had a lot of challenges in the beginning. One of the biggest lessons I learned from another class is you have change done to us and change done by us. And this was change done to the staff. We didn't ask, and we didn't really allow for discussion. We said, we have a CAUTI problem and we're going to do this. So it was very difficult to get staff buy-in on the process. The Foley Huddle lasted up to 30 minutes, sometimes longer. It competed with other priorities, including inpatient rounding and staffing needs. The process did get better after about 2 weeks. We were able to move through things in 15 to 20 minutes more often than not. And at that point, we also gave the staff an opportunity to voice concerns, to raise questions that they had, and it gave us an opportunity to again reiterate that this is a new process. It's not going to take this long forever. We just need to be patient and allow this to become a habit for us. And it has gotten better. So 2 weeks later, we were down to about 10 minutes. And I can tell you that even in the era of COVID, we can be done reviewing all of the Foleys in the house. And we've been averaging 20 to 25 a day with our COVID census. We can be done with all of the Foleys in 5 to 10 minutes because we've gotten very proficient. So the buy-in was hard, but people now see where it pays off. We also had to create a culture change, which was vital to ensuring that every nurse came to Huddle each day prepared to discuss every Foley. Because when we implemented this Foley Huddle, we said, you have to come to Huddle at 8:30 in the morning, prepared to talk about all of the Foleys on your unit. And that was not an expectation prior to implementation of this Huddle. The staff nurses actually reproduced a Foley audit for their units, and you can see that on your screen. So I think it was one of the ICU nurses who helped to create this to help streamline their review process. The night shift charge nurses complete the audit, and they email it to the day shift charge nurses who can review it, make sure there's no changes before the 8:30 huddle. The team found it invaluable for everybody to participate in the entire discussion so that we could all learn. I might have a problem on my unit today with the Foley, but that problem could appear on another unit tomorrow or the next day. So we really felt like everybody needed to participate because we were learning together. And then ultimately, the assistance provided in the huddle increases perceived value to the bedside nurse whenever it helps to decrease their workload. You know, we got to a point where we were able to change the short-term orders, the temporary orders, to long-term when it was appropriate. And that helped the bedside nurse because they weren't having to ask the doctor every 2 days, do I need to leave all of these Foleys in? We also created a closed-loop communication, which was an email distribution list to make it easier for the leaders to send the post-huddle email to the correct team members Monday through Friday. And then we had an additional CAUTI identified on a weekend when no huddle occurred. And that event right there is what really solidified this process in Careplex for everybody involved, because we saw we could have prevented this. Had we taken the time to talk about our Foley on this day, we could have prevented this CAUTI. So it really helped to overcome all of those challenges. Next slide. The next thing we had to work on was physician engagement, and I'm going to actually hand this to Tracey because this was really her success, and that we got our physicians on board from the beginning.
Yep. So what we did with this was not only speak with both the hospital and emergency physicians to help them understand what we were going to start doing, that they might get requests from this team if we had recommendations to things. And it wasn't always, I think the biggest part of it wasn't always you have to take this Foley out, but we were also making recommendations of this is probably more appropriate for a long-term order so we don't have to call you every 2 days to renew. Hey, I noticed that the nitrite and leukoesterase on your UA were positive for this patient who came in with a Foley when they were admitted. We might want to change the Foley out and get a fresh culture because it looks like it could be indicative of them having a UTI, and that's the reason for their sepsis. So we tried to make sure that we were bringing them value from the beginning. One of the biggest things that helped solidify that was inclusion of the hospitalist nurse. So at the beginning of this, she joined us for each of our huddle phone calls. She called in rather than came in person because it was more convenient for her, which was fine with us. And what we did was identify which of the Foleys needed physician follow-up so that when she went to our multidisciplinary rounds at 10 a.m. every day, she could say, Dr. Mulligetta, your Foley in this room needs XYZ. Can we do that? Absolutely. So it just helped kind of make everything run a little quicker. And then after we solidified that process, she doesn't join us via phone any longer, but she still gets our daily emails. We just stick on there which ones need to be followed up in MDRs, and she's got it taken care of. And I think that inclusion really helped those teams value the input of our group quite a bit more and made it successful. Lastly, with the physicians, we really started promoting the CAS UA with microreflex. So this is a urine analysis with a microscopic examination. So if there is a presence of nitrite and leukoesterase, it automatically reflexes to have a culture. The difference is, instead of going straight to a culture, which you now have to wait 3 days for, to see whether or not anything grows, and in the meantime, you know, the patient's sepsis might be worsening because you don't know. They might be getting heavy-hitting antibiotics, which is increasing your C. diff risk. We can tell just by UA whether or not it's indicative of the infection is coming from the urine or from another source. So that really helped them narrow down their sepsis focus a little better, and helped us catch UTIs on patients that came in with Foleys quite quicker, because that was a lot of things that burned us with a lot of those CAUTIs that we had before 2017, was patients that actually came in with infected urine that we didn't catch. So that was really valuable for us. Next slide. So basically, what you really want to know is, how did it work? Next slide is the results. These are our results. So what you're looking at first is the blue. That is Careplex in specific. So like we talked at the beginning, in 2016, we had 8 CAUTIs with a 1.48 infection rate. In 2017, those first 9 months were 9 CAUTIs, which gave us 1.75. So we finished the rest of 2017 without having another one. And in 2018, we had 1. And that one was the one on the weekend that actually the patient did have infected urine prior to the Foley. They didn't have a huddle on it. They didn't send the cath reflex. And in fact, the patient had an abscess that had burst in his bladder. So it was not related to the Foley, but because we could not prove that, it became a CAUTI. So that's that one in 2018, which is painful for Krista and I, but we deal with it. But you can see it was pretty dramatic results. So because our results here at Careplex were so dramatic, our entire Sentara system ended up implementing this huddle as well. And so you can see their results in the, I guess, beige color, if that makes sense. So 2017 was their baseline year for the whole system. So we saw a 16% decrease from the baseline year of 2017 for all of Sentara. For those of you who aren't familiar with Sentara, know that we have 12 different hospitals, and we have small community hospitals that are 80 beds. We have a large teaching hospital at 525 beds. So there's a lot of different hospitals that feed into that result. So that was the infection rate trends. If you'll go to the next slide, is the device utilization trend. You know, we frequently say you can't get a CAUTI if you don't have a Foley. So we also saw really dramatic decreases in our device utilization rates. So Careplex, we had an 8% decrease in our baseline of the Foley device utilization. Sentara as a whole saw an 18% decrease. And one of our hospitals had a 50% decrease in their Foley utilization after they implemented this process. So it was really dramatic. Next up. So again, it goes back to saying, if you don't have a Foley, you're not going to get a CAUTI, and that was the lesson we kept kind of rolling back. And so by decreasing and looking at all of these Foleys every day, decreasing which ones we were actually utilizing, the results followed with the CAUTIs as well. Next slide. So it's all about replicability. It's nice that it worked at one hospital, but like I said, it worked at all of our hospitals. I think there was one that pretty much stayed about the same on their CAUTI rates, but all of us had a decrease in Foley utilization, and 11 out of the 12 hospitals saw a decrease in our CAUTI rates. We also, this huddle process was so successful, we've expanded upon it even since then. So we started here at Careplex using this to then start looking at all of our patients with Bristol 6 and 7 stools to help decrease hospital-acquired C. diff infections. And we saw a 70% decrease with the same huddle process on our C. diff infections from 2018 to 2019. And so that was so successful that, next slide, this model is now system-wide toolkit. It's about to roll out to ensure an HAI safety huddle with CLABSIs, CAUTIs, C. diff, and HAPI prevention rolled into these huddles. Even with all of those things, it still, here at our house, takes about 20 minutes on average. You know, you have your days that there's less devices, it takes a little less. You have your days that there's more devices and it takes more. It may look a little different at each one of our hospitals. At Norfolk General, which is a much larger hospital, they do theirs, well, now all of us are having to do it by phone thanks to COVID. But they do theirs by COVID, and rather than reviewing, the facilitator reviews every device in the house prior to the phone call. Then the phone call is focused on anything that requires follow-up, because if we kept everybody on it to look at every single line and Foley and et cetera, then it'd be a really long phone call. So there are ways to kind of customize it to work to the size of your hospital, but in essence, it just works. Next up. So this is our contact information, and at this point, we are wide open for questions.
Thank you guys so much. That is truly an example of a success story. And I commend you for putting your facility out there and kind of sharing your results from 17 and moving forward and your journey of success. Anyone that has any questions, please enter those in the question box on your control panel. And I'll just ask, what were your results of the external collection devices? Did you see that that helped with your Foley utilization?
Yeah, so one of the big things that we did, that was in 2019. Last year, I was the system lead for CAUTI prevention for our hospitals, so we did a big project where we looked at all of our supply rooms across the system and made sure that every single nursing unit, every ED, every place that could potentially put a Foley in, also had access to all of the alternative devices, so that it wasn't just someone necessarily wetting themselves. You know, you've got condom catheters, we've got the condom pouches. We made sure everyone had all 5 sizes of condom catheters. We were one of the first hospital systems in the country to test the PureWick device, which now I don't know that we could live without. So making sure that all those devices were available and out there so that the nurses had other options other than a Foley.
Right.
And the bias, that was great.
Great. We do have a couple of comments. The first one is excellent presentation. How do we get the slides to share with our team? And if you'll notice in your control panel, if you can access it by touching that red arrow, somewhere on your screen will be a control panel and there's a handout section. If you can't access it that way, I'm happy to send out the slides to the group that joined us today. And next comment is, excellent presentation. Love your energy and making it fun.
Thank you.
That's
if you
right.
can't have fun, why do it?
That's right. Got to make CAUTIs fun. Huh? Well, I think that that'll sum it up for today. I want to thank you again for taking time out of your busy schedule and love these strategies that could reduce CAUTIs, not only in the Sentara system, but throughout the state of Virginia. So many thanks. A reminder to the group, our next webinar in the series will be Wednesday, September 16th at the same time. Our presenter will be Alicia Fink from Children's National, and she'll be discussing opportunities to drive down employee injury rates. So because there are no other questions, I'll remind you to answer the brief feedback survey at the completion of the webinar. And thank you so much for attending, and thank you guys for the presentation. Have a good rest of your day.
Thank you, everyone.